In this lecture series, we're going to be looking at pharmacology for the infectious process, specifically looking at those medications that are effective against bacteria, viruses, and fungi. So this first part then is going to look at specifically bacteria and antibacterial agents. Our objectives for this part of the lecture are that you should be able to explain a couple of terms, antibiotic susceptibility and bacterial resistance. You should be able to explain how each of the following drug classes work, and that would be the classes of penicillins, cephalosporins, aminoglycosides, tetracyclines, sulfonamides, and fluoroquinolones. In addition, you should also be able to list some common adverse effects that come from antibiotic therapy and specifically related to each of these groups of antibiotics. So a little bit of background on bacteria themselves to get us all on the same page. If you recall, bacteria are living single-cell organisms. They're kind of found everywhere. We all have bacteria that is endogenous to us. Some of them are good bacteria. We would call those non-pathogenic because they do not cause disease. And those bacteria that are pathogenic are the ones that cause disease. And those are the ones we're particularly going to be looking at when we're talking about antibiotic therapy. There are thousands and thousands of different types of bacteria, and they are classified by their shape and by how they're arranged. So the basic shapes would be spherical, round, and they're called cocci. Rod-like are bacilli. The curved ones are spirilla. And then they can be arranged in pairs, which is diplo, in chains, which is strepto, or in clumps, which is known as staphylo. So that's just a recollection of where those names that come from in the bacteria that we're going to be talking about when we're talking about antibiotics and their treatment. Okay, a couple terms that I just want to make sure everybody's familiar with as we're going through this is, first off, what's an antibiotic? And an antibiotic is an antibacterial drug typically obtained from other microorganisms, though we do have some exceptions. But originally our antibiotics, that's where they came from, other microorganisms. And we now get them today from two major sources. We either get them from soil originating microorganisms or by chemically synthesizing them. If we're talking about this term called antibiotic susceptibility, if we look at it, think about what the word susceptible means. The word susceptible means vulnerable to. And when we're talking about an organism being susceptible to an antibiotic, it means it's vulnerable to it. The antibiotic will work on eradicating the organism. That is called antibiotic susceptibility. That's determined through a process called culture and sensitivity. That's, remember those good old fun throat cultures that you've had done? That's what they're doing. They're taking a swab of the bacteria. They're going to grow it and test it and see what antibiotics will work against it. Culture and sensitivity. It is the ideal route to take when choosing an antibiotic for somebody. The second term that we need to look at is that of bacterial resistance. And bacterial resistance occurs through mutation. What happens is the bacteria get exposed and they start to mutate so that the antibiotic cannot kill it as it regenerates. Think about what are some things that may cause bacteria to mutate or may cause bacterial resistance. One of the proposed things right now is that we're using so many antibacterial soaps and preparations in that out there that we may be creating superbugs by doing that. The other one is exposure to antibiotics that don't totally eradicate the bacteria. So you take an antibiotic, it kills some but doesn't kill all of them. The new bacteria will mutate, or the growing reproduced bacteria will mutate, and then they will be resistant against that antibiotic. So the next time the antibiotic is administered for that bacteria, it doesn't work. And we'll talk about that some more as we go through this, but it is a serious problem with overuse of antibiotics or inappropriate use of antibiotics. And the last term to get familiar with is that of chemoprophylaxis. Big word, but if you break it down, chemochemical and prophylaxis, before or ahead of a disease. What we're talking about here is the use of antibiotics before an infection actually occurs. Certain people should really receive chemoprophylaxis before they're having any invasive procedures, such as dental work or surgery. Anything that could potentially introduce bacteria into the blood. And one of the populations of people that are highly susceptible, that we use this for, would be those who have known heart murmurs or known valve problems, heart valve problems. One of the things that can happen is organisms can get in, and specifically we're thinking of Streptococcus as one of the big ones, gets into the body and it'll cluster around, catch on leaky valves in the heart, and it'll damage them and eventually cause something called rheumatic heart disease. So we give chemoprophylaxis to anybody who would be at risk. It has one of those sloppy valves that just isn't working right, that could potentially collect those organisms on them. And what we'll do is we'll give them a couple doses of antibiotic prior to the procedure. Usually we give them a dose during the procedure, and sometimes if we're really concerned, we also might follow up with a dose after the procedure. Some of you may actually do this before you go and have dental work done. So that process is actually called chemoprophylaxis, and it's for those high-risk patients that we actually want to head off potential infection before it occurs. So let's look at our first classification of antibiotics, and that would be our penicillins. Now, penicillins are derived from a variety of species of the Penicillium mold. As I said, soil organism is where a lot of our antibiotics come from. And then we have various forms of penicillins within that, and then what we've done is the mold has been altered through the addition of various salts that then will slightly alter and change the penicillin, making it more effective against certain bacteria. So now, how do they really work? Penicillins themselves interfere with the bacterial cell walls. They cause the cells to burst. There's this substance called beta-lactam, and beta-lactam binds to the enzymes in the bacteria that are necessary for creating the cell walls. What happens then is the antibiotics lead to the formation of defective cell walls, and this causes the bacteria to release autolytic enzymes. Autolytic, against self, and lysis means to break up. So these autolytic enzymes then cause the cells to break up and die. So penicillin interferes with the cell wall synthesis, causing enzymes to be released that will end up destroying the cells. Penicillin is really called a broad spectrum antibiotic, and by broad spectrum what we mean is it works against gram positive and gram negative bacteria. Okay, and if you remember from way back when, biology, we use a stain called a gram stain to determine if it's gram positive or gram negative. So penicillins work against a really broad spectrum of bacteria. So if you take a penicillin, what are the adverse effects you might experience? Well, some of the minor ones, such as nausea or rashes, occur and can occur fairly frequently. Diarrhea we'll see sometimes with oral administration too. So nausea, vomiting, diarrhea, and rash are pretty common for most of our antibiotics. So specifically though with penicillins, what are some of the serious things we need to watch for? And as a drug class, penicillins cause the highest incidence of drug allergies. So the most incidence of drug allergies recorded come from the group of antibiotics called the penicillins. You may see things like hives, rashes, fever, and then could lead to the very serious condition, convulsions and anaphylaxis. Anaphylactic shock being that where the entire body goes into a histamine release and it literally shuts off airways and fills everything with fluid. So that is the most serious reaction that we do see, and sometimes from people who have penicillin allergies. Our next class of antibiotics is that of the cephalosporins. The cephalosporins, if you link them up with penicillin, you're going to remember them very easily because cephalosporins, basically, if you look at the word sporin, it is again comes from a mold and as a result has very, very similar properties to penicillin. Its mechanism of action is exactly the same as penicillin. And it works against broad spectrum gram positive and gram negative bacteria, just like penicillin. You had one of these on your drug list, and that was the drug of Rocephin. A couple of other ones that you may hear or may have heard of that we commonly use are that of Kefzol and of Ancef. Now, when we're talking about allergies, or I'm sorry, adverse effects that come along with cephalosporins, again, commonly GI disturbances, diarrhea, nausea, vomiting. Also common to see rashes with these. One of the things we need to watch with particular first generation of cephalosporins is something called nephrotoxicity. And nephrotoxicity is damage to the kidneys. So we need to make sure patients are staying hydrated when they're taking these so they don't get damage to their kidneys. And anybody who's may already have some kidney damage, we might want to avoid these in. Another interesting thing with cephalosporins is they can cause a disulfiram reaction when combined with alcohol. Disulfiram you might not know by that name, but you might know it by the name of antabuse. And disulfiram or antabuse is a medication that we give to alcoholics to deter them from drinking. What happens is when taking this medication, if someone has a drink of alcohol, they will become violently ill, nausea, vomiting, and headache. They become miserable. So it deters them from drinking the alcohol. Interestingly enough, we also see this with some cephalosporins. So you do want to, even though we always encourage patients not to drink any alcohol when they're on medications, with cephalosporins, you do want to make sure no alcohol because they could immediately become violently ill and sick, nausea and vomiting and headache from it. The nice thing about cephalosporins is they do have a lower allergic reaction rate than the penicillins. So you're less likely to be allergic to a cephalosporin than you would a penicillin. However, Here's the one you have to be careful with these. Cephalosporins, because they come from a mold similar to that of penicillin, we can see a cross-sensitivity. That means if someone is allergic to penicillin, there is a good chance they may also be allergic to cephalosporins, even though they've never taken them before. It's a cross-sensitivity reaction. So if we come across a patient going to give an antibiotic and we see on the chart that they're allergic to penicillin, we will also avoid giving them cephalosporins. We will want to go to one of our other classes of antibiotics. The next class of antibiotics we're going to talk about is that of the aminoglycosides. Now, what happens with aminoglycosides is their mechanism of action is quite different from that of the penicillins, in that what they do is they attach to the ribosomes in the bacteria. If you recall back from biology, the ribosomes is where proteins are manufactured. So they keep the bacteria from manufacturing proteins. A way you can remember this, if you look at the term amino acid makes up proteins, aminoglycosides, it may trigger and help you remember that. So essentially what happens when it binds to these ribosomes, the bacteria can no longer produce proteins, and therefore it can't survive, nor can it reproduce. The aminoglycoside group is primarily effective against gram-negative bacilli. An example of a gram-negative bacilli would be that of a Pseudomonas infection. If we're pretty sure we got a gram-negative going on, an aminoglycoside may be a good choice of an antibiotic to use. Now, a couple things to note about them, though. Orally, they do not absorb well through the GI tract. They tend to stay intact passing through the GI tract. So they stay in the GI tract in essence, and they don't absorb very well into the bloodstream when taken orally. Now, this is an advantage, though, if we have someone who is going for bowel surgery, because the antibiotic is good at affecting the bacteria that's actually living inside the intestines. So it will decrease the bacterial count in the intestines. So orally it may be used prior to bowel surgery to kind of decrease the bacterial count in the bowel. If we're looking at treating something, though, that is other than inside the intestines, we will probably give this medication then parenterally. Usually IV is the most common. We can also give it IM. Therefore, it will get into the bloodstream and will be effective against bacteria in all parts of the body. You did have one aminoglycoside on your drug list, and that was garamycin. So garamycin is an example of an aminoglycoside. Aminoglycosides do also have some adverse effects, as everything else. Again, nausea, vomiting, and diarrhea if we take it orally. That's very common. Nephrotoxicity, which we talked about earlier with cephalosporins, but also ototoxicity. And ototoxicity is damage to the nerves of the ear. And what can happen is you can see hearing loss in people who are taking aminoglycosides. So we do need to watch when we are given parenteral aminoglycosides, monitor hearing. And if we start to see hearing loss, we may need to discontinue this. And I've commonly seen this in infants, where we will do a hearing test on an infant prior to starting administration. And then frequently throughout administration of IV aminoglycosides, we are checking on them, on their hearing, to see and make sure that we aren't causing damage to the nerves of the ear. Our next group is that of the tetracyclines. And The tetracyclines are a broad spectrum antibiotic, and they bind to the ribosomes similarly to the aminoglycosides. By binding to the ribosomes in the bacteria, they inhibit protein synthesis. Now, the nice thing is they're not just gram-negative like the aminoglycosides. They will affect both gram-positive and gram-negative bacteria. So they're a little bit more broad spectrum than the aminoglycosides. Two of the examples of tetracyclines, solidine and doxycycline are common ones that we give. So they may be some terms or some medications that you may have heard, and they are both tetracycline medications. Couple words to the wise, though, about tetracyclines that you need to be careful with. Tetracyclines will bind with calcium, and therefore we have to be careful who we give them to. We don't want to give them to children below the age of 8 and women who are pregnant or nursing, because the drug, being that it's binding to the calcium, could then be deposited in the bones and the teeth. And what we see from this is we can see discoloration, particularly of the teeth, and we can also see depression of bone growth. So we do want to watch that in those populations. Be careful that we're not giving them to children or to pregnant or nursing women. The other thing about that is, remember I said it binds to calcium, so things like calcium supplements or antacids should not be taken along with tetracyclines, nor do you want to take these with milk, because again, what will happen is the tetracycline will bind with the calcium in these substances, and then it won't be absorbed into the system. So you will have less absorption and less effectiveness of it. So this is one that on the label will say do not take with milk. But that includes don't take it with an antacid or your calcium supplements or your mineral supplements. Most common side effects associated with tetracyclines are nausea, vomiting, and diarrhea. That should be ringing a bell at this point for you after a couple classes of medications. We can see one thing that we do see with tetracyclines, and we can see it with other antibiotics too, but this group seems to be particularly susceptible to superinfections. And what that means is we actually end up killing off, not just when we're killing off bacteria, we're not just killing off the bad bacteria. We may also be killing off some good bacteria. And so what sometimes can end up happening is we end up with a secondary or a superinfection because we've killed off bacteria that were keeping other things in check, such as fungus, particularly the fungus known as Candida albicans, which causes yeast infections. So it is not unusual for someone who is taking a tetracycline to then end up with a yeast infection because we've killed off the bacteria that have kept the natural growing yeast on the body in check. Though I caution, it's not just tetracyclines. You may see that with any antibiotic. This group just seems to see it a little bit more frequently with it. Adverse effects also would include something called photosensitivity. And the photosensitivity means that someone, after taking a tetracycline and being exposed to sunlight, can get a very exaggerated sunburn. So we also caution people on tetracyclines to stay out of the sun, or if they go in the sun, they need to be covered or need to put on some heavy-duty sunscreen. Because even though there's someone who may go, oh, I tan, I don't burn, the tetracyclines can change that, and they can end up with a serious exaggerated sunburn. All right, the next group is that of our sulfonamides. And sulfonamides are a little different from the ones we've talked about previously, and that they're a group of synthetic medications. And they were actually, interestingly, discovered in 1935 as a byproduct of the dye industry. So from making dye, DYE, we ended up, as one of the things we're cast off from the process, with an antibiotic that was effective against both gram-positive and gram-negative organisms. Um, as I said, it came out in 1935, and it became used in everything. If you've ever watched episodes of like MASH, you hear them calling for sulfa drugs, sulfa drugs. That's what they were talking about, is sulfonamides. It ended up very much like penicillin being given to everybody under the sun for everything. As a result, we start to see the development of bacterial resistance. So sulfonamides have really become very ineffective because we overused them and gave them too much, and as a result, we developed a lot of bacterial resistance. Basically, what happens with sulfonamides is they block the synthesis of folic acid. Folic acid is a B vitamin that is required to make new cells, not just in our human bodies, but also for bacteria to make new cells. So it prevents bacteria from synthesizing folic acid, and as a result, they can't reproduce. Therefore, they die. The most common use we have today for the sulfonamides is that of a topical application, particularly in treating burns. It prevents burns from becoming infected. And if you've ever had a severe second or third degree burn, you may have been prescribed something called silver sulfadiazine, in short called Silvadene. And Silvadene is an incredible miracle drug for helping burns to heal without them become infected. So it is the primary use that we see anymore of the sulfa drugs. So if you are taking a sulfonamide, what are some of the possible adverse effects that you could experience from these medications? Of course, I probably don't need to say this at this point: nausea, vomiting, and diarrhea. Um, I'm starting to sound like the Pepto-Bismol commercial. In addition to those, usually most of the reactions are limited to the skin, rashes, itchiness, and we also may see some photosensitivity with these. There is also a very serious skin condition called Stevens-Johnson syndrome, which can occur and can be fatal. Okay, we're down to our last group of antibiotics that we're going to talk about. And these are the fluoroquinolones. The fluoroquinolones are synthetic antibiotics that again have a broad spectrum of bactericidal activity. Even though they are broad spectrum, they are really especially effective against gram-negative organisms, but they do affect gram-positive organisms too. What these guys do is they inhibit a bacterial enzyme, specifically deoxyribonucleic acid gyrase. You don't need to remember that, but it's helpful to know that the enzyme is essential for synthesizing DNA. So by interfering with the synthesis of DNA, the fluoroquinolones then keep the bacteria from replicating and reproducing. There were some medications on your drug summaries that were fluoroquinolones. Two of the most common ones that we see being used are Levaquin and Cipro. And often when I mention Cipro, people go, "Oh yeah, I've been on it," or "I know someone who has been on it." So those two, they are probably our most popular fluoroquinolones that we give today. Adverse effects of fluoroquinolones: uh, nausea, vomiting, headache, diarrhea, and rash are the most common that we see with this. You may also see some dizziness and that comes along. When you're reviewing your antibiotics, for my purposes, pretty much you've determined that all of them cause nausea, vomiting, and diarrhea. So when we're looking for adverse effects, make sure that you're focusing in on the ones that are not nausea, vomiting, and diarrhea, those unique ones to each individual class of antibiotic, and focusing in on just the unique properties of each individual class.